thank you, Cynthia, for the invitation, and we really appreciate the opportunity to get to talk about dysfunctional lens syndrome in this setting. We all know that we have an aging population. The numbers are staggering. When we look at, we're here on the brink of 2020. There are 2.1 billion presbyopes out there, each with two eyes, 4.2 billion presbyopic eyes worldwide. So we've got our work cut out for us because people are not aging gracefully anymore. They are looking for options. And so the age-old question in terms of how we approach the presbyopic patient for surgery really had been that around which lens do we work on. If somebody's coming for a surgical fix, do we do this on the cornea or do we do this on the internal lens? The cornea has always been thought of more readily acceptable. It's kind of what patients have in mind when they come in to see us for LASIK, perhaps. Less invasive. We can do this in our in-office laser suites, and less expensive. But the lens, if it makes sense, we're actually addressing the source of the problem, which I'm sure you would agree is usually a good idea. And it can improve visual quality, as we'll see. This is a permanent solution and often can be therapeutic. But we have more and more options in the horizon. Drops and minimally invasive scleral procedures with use of laser. So not only that, but we're broadening our understanding of the pathophysiology of the disease process. So Daniel Goldberg, with his cover article in JCRS in 2015, has taught us that there's actually a ligament on the capsule and zonules that attach to the vitreous. Who knew that? So enter the term dysfunctional lens syndrome. This has now been accepted by the American Academy of Ophthalmology, which is quite interesting. So we're hearing more and more about this as simply an attempt to characterize the aging changes of the human crystalline lens. This starts with presbyopia. In the second stage, that's the first stage. In the second stage, we get some early opacities. And then the third stage, this becomes manifest to the point that it affects patients' daily activities. And this is where Medicare kicks in. So we've seen this now in the ophthalmic news. Again, stage 1, presbyopia. Stage 2, early opacity. Stage 3 is a cataract. Well, what's this? This is my eye. I'm an incipient presbyope, and somebody conveniently left these reading glasses up here, and whoever they are, I might actually need to borrow them because I just started wearing these things. And luckily, I have great image quality falling on my retina, as you can see, but I actually need help now. So I'm really excited about the idea of a pharmacologic intervention, and we've got a number of these opportunities that we're working on here in the not-too-distant future, hopefully. But let's say I get sick of drops and I'm ready for something more permanent, perhaps, because I'm now using drops all the time and I might even need readers on top of that. So I might be thinking about a cornea-based solution. And this is in a first stage DLS. We can see good retinal image quality still in the green with the objective scatter index and minimal densitometry reading, which still suggests good optics in the lens. It's just not performing well. Well, fast forward 5 to 7 years, now we're starting to get some early opacities. So how many of you have used the term pre-cataract in your career? We're trying to not use that terminology because it's somewhat dismissive to our patients. And we're trying to teach our optometric colleagues these same principles as well, because you don't have to wait. If you're a good candidate and this makes sense, we can actually address these and go to the source of the problem to improve retinal image quality. And that may make the most sense in stage 2 dysfunctional lens syndrome, as we see here. Unless this is a high myope, then we really need to pay attention to additional risk factors, particularly males. And it's actually been shown over axial length of 25 millimeters. These are not insignificant risk factors. So when we look at this over the aging of a human crystalline lens, it really starts to make sense when we think about we probably should be addressing the source of the problem if there is opacity. And now we have advanced diagnostics like the eye trace that shows us that we can actually subtract the internal aberrations. There's the Dysfunctional Lens Index that actually shows this objectively. Here in this, somebody in their late 50s looking for LASIK to get out of their bifocals. Well, the aberrations are coming internally. This, if we do blended vision LASIK, we're leaving them with aberrations and poor image quality, right? The other nice thing is we can say in good faith that we are preventing cataracts too. This is permanent, and patients really appreciate that. So more and more, we've got a whole host of opportunities to help the presbyope surgically. And how in the world do we decide which? I mean, this is almost going to require a fellowship just in presbyopia. So we're really excited. We're going to be launching a study here in the next few months with the 2Eyes SimVis vision simulator that allows patients to actually simulate different presbyopia correcting IOLs and in different circumstances. So we can actually customize it with each eye individually and let the patient really get a sense of what it's going to be like. So how do we then do this systematically? Well, here's a proposed algorithm. Basically, if we've got the incipient presbyope like myself, we may be thinking about a pharmacologic solution. If this is now manifest, but still with a clear internal lens, then perhaps a blended vision approach with LASIK, and we have scleral opportunities on the horizon. But once we start to get lens dysfunction stage 2 with opacity, then we want to think about going to the source, again, keeping in mind risk for retinal detachment. And of course, stage 3, this is a cataract, then that's easy to figure out. So putting this all together, this is how we do it in our practice. We have a standard operating procedure depending on what the patient is referred over for or what they call in for, mostly based on age. And this helps my technicians put them on our track for workup and really kind of creates a flow so we know how to address these patients. Thanks so much.